have the great pleasure today of talking to you about cardiac rehab and how it fits into the pathway that we're talking about today. So I think most people understand or have a basic understanding of what cardiac rehab actually is. But for those people who have been away for a while or potentially not had too much interest in it, in general, the World Health Organization would define it as a sum of activity designed to bring a patient back to their best possible self and by their own efforts. And traditionally, it's sort of been an exercise-based program. But I just want to, it's interesting that the word exercise doesn't actually appear in the core components of BACPR anymore. The exercise component is integrated within the lifestyle risk factor management, and it's more, it's supposed to be a little bit more open now, and patients are more able to access more components of rehabilitation, which include psychosocial health and medical risk management, so optimization of medicines to be able to ensure that when they're discharged from cardiac rehab, there are accepted secondary prevention targets. So yeah, there's a lot of evidence around heart failure patients accessing cardiac rehab. Historically, again, it's always around quality of life. It makes them feel better. Their exercise tolerance is obviously going to be improved at the end of it. Anxiety reduction, stress management is improved at the end of cardiac rehab. And of course, the cardiovascular risk is managed much better. So there's the need for acute hospital care just for heart failure admissions is much reduced. And all-cause sort of relative risk reduction in unplanned admissions to hospital is much reduced by an effective cardiac rehab program. And that's actually quite comparable to some of the CRT devices and other sort of management things that are available for heart failure patients. So the evidence is there. There's a relatively new paper come out this year about all-cause mortality in heart failure patients. And the reason why I quite like this is that it includes the patients with preserved ejection fraction, where there isn't actually an awful lot of evidence around cardiac rehab for this group of patients. And it has got a lot of sort of outcomes, reducing of all-cause mortality, incidence of stroke, incidental AF, all at 2-year follow-up. So really nice, deep controlled trial on patients for coming through cardiac rehab. And it's also mentioned that sort of specifically for preserved ejection fraction, there isn't actually an awful lot of therapies that we've been talking about this morning that are evidence for these patients, but cardiac rehab is starting to come through as a really good tool now for managing patients out in the community. So we have a body that audits cardiac rehab, and it doesn't give us an awful lot of information about heart failure patients, but it does say that we should have them, which is great. But other than that, there's not an awful lot of information about when we should take heart failure patients, how long we should keep them for, and what the quality of cardiac rehab should be for those patients. And that, as Paul said before, where you are in the region would change the way that you deliver your cardiac rehab. But you'll be glad to know that Cheshire and Merseyside, we're pretty good. We all achieve or try and achieve gold or green standard, it's called, green certification. And most of the services around the area are in that category, just a couple of in the amber. And as you can see, nationally, that's pretty good going. So the pathway, where does it stand in the pathway? It's nice to know that it's actually embedded all the way through. When I was reading it, it cropped up a number of different pages, which again is fantastic. And it's just interesting to sort of to say that the referral from heart failure services into rehab is traditionally coming from when they've had an acute exacerbation. They're managed through the community heart failure specialist nurses. We don't get an awful lot of referrals that come from primary care. It's a massive cohort that as we were saying before, sit at home and they're symptomatic at home and they put up with some of their symptoms, don't necessarily qualify for acute care or management, and potentially have a think about referring them for cardiac rehab. Patients can come more than once if they want to. If they found it really useful at the beginning, maybe had an alteration in some of their diagnosis or their symptoms on a sort of daily basis, they can come repeated times over a number of years if they wish. So who can come? Anybody really with a diagnosis of heart failure. Some services will accept preserved ejection fractions across the patch, or if they've had a recent step change in NYHA. They need to be clinically stable for exercise, where I appreciate that's quite broad, but again, it's just having those conversations with rehab practitioners and see whether at what point you would take heart failure patients within the rehab. And of course, they've got to be willing, as we were saying before. There are loads of contraindications, or loads. There are some contraindications, but they tend to sort of be quite nasty. So, for example, sort of relatively acute, osteoporosis or whatever it might be, but they have to be particularly poorly to not come. Syncope on exercise, funny arrhythmias, exercise-induced arrhythmias, okay, potentially wouldn't take them until they're more stable. Not very well, or in hospital, okay, we won't take those just yet, or if they don't want to come. Okay. So when should cardiac rehab patients be offered rehab? So historically, this has been when a patient is optimised, and I've heard many times this morning that optimisation takes such a long time, and you get them to the point of optimisation and they take a fall off their perch and sort of start again. So there was a lovely statement issued, a position statement issued a good few years ago by our lovely Dr. Joe Jones. Basically saying, so the part in yellow says if they are sufficiently stable to be discharged from an acute setting, then they're eligible for cardiac rehab. So what he's really saying is, get on with it. Okay, I'll probably just skip over that, but in a nutshell, there was a big study for cardiac rehabs for heart failure patients, but of 100% of the patients that came through rehab, it was only 0.8% in that study that actually completed. So again, there's a massive gap there for patients. So COVID sped us up a little bit in terms of evolution of digital options for rehab, which has been fantastic. 16% have supported home-based rehab. And there's a number of different options for all sorts of patients, which are down the bottom there. But the one that's specifically designed for heart failure is called REACH-HF. You may or may not have heard of it. It's most teams across the patch will be able to deliver that. It does require some extra training and a little bit of funding. And it's delivered through either a manual or online, and you see a patient face-to-face to start with, and then you give them prescribed home exercise, and they work through sort of a manual over 12 weeks, and then you see them again at the end. So it's worth kind of knowing whether that your local rehabs offer this type of option for patients, which will certainly widen the access for more poorly patients that like home-based interventions. So challenges across the time, again, we've had the problems with delayed access and uptake. Historic practice has held us back over many years, and we just end up waiting for tests, A, B and C. If we ended up waiting all the time, we'd never actually sort of see a patient come through the doors in the first place. Women are poorly represented, not just for heart failure patients, but in cardiac rehab in general. And so it's our job to be able to provide different options for women, particularly with heart failure patients. And it's good to try and understand that, again, function specific, as we touched on before, there are young, fit young men and women. And if we put them in a sort of normal cardiac rehab for heart failure patients, we'd scare them to death. I think they probably wouldn't come back. So it's to think about where they fit within a rehab program and trying to individualise that for each patient, and just remembering that the LV is not related to your exercise capacity or your VO2. And trying to get the patch all standardised, so each rehab that occurs across Cheshire and Merseyside is trying to get the same standards across them. So there's a big push from the British Association for the BACPR for non-medical prescribers across, within cardiac rehab, which obviously support heart failure patients. So in summary, well, it works, it's cheap, keeps people out of hospital, and it makes them feel better. So really, we want you to refer patients as soon as you feel they're able to attend, and most people should be able to access some type of cardiac rehab at some point. That's all.